Now we're going to talk a little bit about some of the specific disorders of the neonate. Remember that the neonate, by definition, is like the first 28 days of life. It's actually been stretched out to 2 months, at least for infectious disease purposes. The infant of the diabetic mother. Remember what happens during gestation if the mom has uncontrolled diabetes. The blood sugar is high in the mom. The baby, the fetus, sees circulating high blood sugars, and so the fetus has no problem producing insulin. So the fetus produces more insulin and is getting more calories that way. Insulin in and of itself is a growth hormone. So these babies will be kind of big at birth. When the baby is delivered, the cord is clamped, the baby has high circulating insulin levels, but now the sugar levels aren't high, and therefore the baby is a very high risk for hypoglycemia. And so what happens is the baby can have jitters, they can actually even have seizures, they can have other electrolyte abnormalities such as low calcium and magnesium. Typically, these babies have a high red blood cell count, a high hemoglobins. They are described as being ruddy. If you see the word ruddy, R-U-D-D-Y, that's typical. That means that they're very red. They can also use the term plethoric when they're describing these babies in the question. Bilirubin also tends to be high, and they're at higher risk for jaundice. One reason is that they get hypoglycemic, and the enzyme that helps metabolize bilirubin is glucose dependent. So if they're hypoglycemic, the enzyme doesn't work as well, and they can have jaundice in addition to the higher circulating red blood cell counts. So there you go. Findings such as macrosomia, that's a big baby. My rule of thumb is a baby should be 5 pounds 8 ounces to 8 pounds 5 ounces. If they're outside that range, they're too little or too big for a term baby. They can use the term ruddy or plethoric. These babies are at higher risk for respiratory distress syndrome. Even though they are big, sometimes they are preterm, and so the surfactant has not developed as well, and they're at risk for respiratory distress syndrome. They're also at higher risk for cardiac problems. Babies born of infants of diabetic mothers are at risk for hypertrophic cardiomyopathy in particular. Usually it resolves by 6 months of age. If it doesn't, then they'll really need follow-up. They're also at risk for gastrointestinal problems, what we call the small or lazy left colon syndrome, and it presents with babies that don't pass meconium, and it looks almost like a microcolon that you can see with cystic fibrosis. They're also at risk for some anatomical problems like a hypoplastic sacrum, which can cause other abnormalities. The treatment of infants of diabetic mothers, well, first of all, you want to make sure that the mom is treated during pregnancy so she's not hyperglycemic. You want her to be controlled. The other thing is once the baby is born, you want to monitor the blood sugars, and if they get hypoglycemic, you need to provide them with possibly IV glucose until they reset their pancreas and the insulin that they secrete. So this is an infant of a diabetic mother. He is currently receiving some IV, as you see right there. It could be dextrose that he's receiving. He also has an NG tube, so they may be feeding him that way too. But you can see he's a big, big baby. He will require probably some insulin for a while, and then they taper it down as, he requires dextrose, and they'll taper it down as his insulin levels decrease. Respiratory distress in a newborn. Again, look at the age of the baby. Now, most respiratory problems in an infant are of respiratory causes, but here you see that there are other non-respiratory causes of respiratory distress in the newborn infant. We're going to go through these, but always look at the age. When we talk about the non-respiratory problems, these could be cardiac problems. One way of knowing if it's a cardiac problem or not when you're reading the stem of the question is if they give this baby oxygen and the patient's saturations do not go up, then think of a patient that has some kind of a fixed shunt, and that means that it's probably a cardiac problem. Other non-respiratory problems of respiratory distress, so you can see cardiac problems can cause heart failure. Hematologic problems can lead to cardiac problems actually and can cause respiratory distress, such as a baby that's anemic can go into high output heart failure. A baby that's polycythemic or very, very ruddy, that heart, it's really pumping sludgy blood, and so it can go into heart failure. Other causes of respiratory distress include infectious causes. So a baby that's septic can have respiratory problems. A baby that has a metabolic problem like hypoglycemia or other inborn errors of metabolism can sometimes manifest with respiratory problems. And certainly neurologic problems such as bleeds or seizures can sometimes cause respiratory problems. It's very difficult when the baby's breathing. They can be tachypnic, they can have nasal flaring, they can have cyanosis, they can have retractions. All of these things are nonspecific. They just tell you it's respiratory distress. However, the most common causes of respiratory distress in a newborn are respiratory. Okay? And again, the age is very important. If they mention a baby that is preterm, then you should think of respiratory distress syndrome as the major cause of this baby's respiratory problem. If the baby is a term baby, and especially if they describe a short second stage of labor, or if they describe a baby that had a C-section, they don't get that vaginal squeeze, it's a term baby, they're going to start breathing fast just to blow off some of that retained amniotic fluid. That's transient tachypnea of the newborn, or what we call TTN. For meconium aspiration syndrome, what you have to look for is that when they rupture membranes, or at the time of rupture of membranes, thick meconium. Those are all clues to lead you down one path or the other. Other causes of respiratory distress include a pneumonia. In that case, they might give you temperature or a chest x-ray or cultures or something like that. A diaphragmatic hernia. When they mention a diaphragmatic hernia, look for a baby that is born with a scaphoid abdomen. So they'll mention respiratory distress. Look for a scaphoid abdomen, and you will hear bowel sounds in the chest. That's a clear evidence to make you think of diaphragmatic hernia. And choanal atresia, they'll describe a baby that is blue and pinks up during crying because now it's breathing through his mouth. And we're going to discuss these and show you some x-rays. This is respiratory distress syndrome. It's caused by a lack of efficient surfactant. Remember that surfactant, there are various forms of it. It is created by the type 2 pneumocytes, and surfactant is responsible for maintaining that surface tension in the alveoli so they don't collapse with every breath. Well, if the baby is born preterm, they don't have enough surfactant or they don't have enough effective surfactant, and so they get a lot of atelectasis. The baby may be born with normal APGARs, but at some point over the next, either right away or over the next few hours, starts to develop respiratory distress. Another important word that they'll use on the exam to describe respiratory distress, regardless of the etiology, is grunting. That's the sound that the baby makes when it breathes. These babies are creating their own positive end expiratory pressure to try to keep the alveoli open, and when the air goes out for them to take the next breath, you'll hear the grunt. The best initial test for any of these diseases is a chest x-ray. Okay, so here you're going to see a chest x-ray. I think I have another one after this, a little bit better. Look for the description ground glass appearance. What's happening is that all those alveoli are starting to collapse, and so the lung looks kind of solid. In fact, the more severe the disease, the wider the lungs are going to look on the chest x-ray, and sometimes it looks almost like the liver. So here we see a completely whited out chest. And if you look, this is what the liver looks like. It's pretty hard to tell the difference. The heart border is not very clear, and sometimes you'll see what are known as air bronchograms. So the best initial test is going to be a chest x-ray. The most accurate test basically is, first of all, you want to know before the baby's delivered what the gestational age is, and some people will do LS ratios to see if they have enough mature surfactant. The treatment is going to be basically supportive. You are going to, if it's necessary, intubate the baby. Some people will give surfactant. In fact, most neonatal ICUs now will give surfactant as the first treatment once they have the diagnosis. Surfactant certainly helps these babies. Also, many times they'll be treated with antibiotics empirically simply because you don't know if there's an infection or not. And obviously, prevention is the most important thing. Try to get the baby to term. One of the things that they'll do with the mom, and this is an OB question, but we'll give it to you free on pediatrics, is they will give the mom steroids prior to delivery. So they'll try to slow down or stop the preterm labor. Try to get the baby to term. The next thing is they will give the mom steroids to help with lung maturity. Once the baby is born, steroids don't help anybody, so you don't need to give them then. Surfactant and supportive therapy is the way to go. This is another picture that again shows the baby with RDS, and you see the heart border is a little clearer here, but again you see these areas that are kind of blackish. That's what they call air bronchograms, and everything else along here, more so than on the other side, is what they call the ground glass appearance. Transient tachypnea of the newborn, like I mentioned, is basically because there is some retained fluid in the lungs and the baby's just trying to breathe it off a little bit faster. So again, look for an infant that is term, look for a rapid second stage of labor or a C-section. Treatment usually is oxygen and supportive, and after a couple of days they get better on their own. The X-ray doesn't look too dramatic. You can see a much sharper heart border here. You can also, sometimes you'll see a little bit of fluid in the fissure, but the X-ray doesn't look terribly abnormal, and these babies are just basically tachypnic, and over the first couple of days they get better and it goes away. This is meconium aspiration syndrome, is the one that you will probably have a history of meconium at some point when they rupture membranes. This shows the fact that the baby has actually stooled and passed meconium into the amniotic fluid reflects some kind of asphyxia or hypoxia, which causes relaxation, some kind of stress on the fetus in utero, typically shortly before delivery. And when the baby is delivered, if it has amniotic fluid and all this stuff around it, when it takes a breath, it will aspirate the meconium. Now, meconium is very thick and sticky, and when you aspirate it, it causes all kinds of problems with local collapse and aspiration pneumonia and shunting, and it can lead to what we call persistent fetal circulation, or what we call primary pulmonary hypertension of the newborn because of the hypoxia and the vasoconstriction. This will cause more shunting of blood, of unoxygenated blood, and that's what we call it. The old term was persistent fetal circulation. And that's one of the complications of meconium aspiration syndrome. The diagnosis is going to be made with basically when you see meconium at the time of rupture of membranes, and the best initial treatment is prevention. So once the head is delivered, you want to suction the oropharynx very well and suction sometimes below the cords and get some of that stuff out. Afterwards, it's just going to be supportive treatment. Here we see a patient with meconium aspiration syndrome, and basically it's like an aspiration pneumonia. It can go anywhere. Like most aspiration pneumonias, you can see things on the right side, but in this case, you see a little bit everywhere. This is a diaphragmatic hernia. Remember, I told you it's a baby in respiratory distress with bowel sounds in the chest and a scaphoid abdomen. The abdomen is scaphoid simply because the contents have gone up into the chest. This usually happens a little bit earlier in utero. It's most commonly seen on the left side. On the right side, we don't see it that often because we have the liver that protects the diaphragm. So what happens is you have a diaphragmatic opening, and all the bowel tends to take the path of least resistance, and it goes up. So all of this stuff that you see on this X-ray here is all bowel in the chest. Notice that the endotracheal tube is shifted away from the pathology, and the lung and heart on that side is also, the lung is compressed. So the lung on the affected side does not develop normally. The lung on the opposite side tends to be also damaged because it has to do all the work, plus everything has been shifted over to that side. Again, a chest X-ray is the first test, then you're going to see everything. And securing the airway and then surgery is going to be the way to go. Couple other things that you'll see in the newborn. Meconium ileus. Meconium ileus is when you have this thick inspissated meconium. It does not move along and basically causes an obstruction. Meconium ileus should be thought of as patient having cystic fibrosis until proven otherwise. Most babies will stool by 24 to 48 hours of life. If they don't stool, one of the things you need to worry about is meconium ileus. Another one is an imperfort anus. Another one is Hirschsprung's. Okay? The imperfort anus is easy to see because you just look. The meconium ileus, you need an X-ray. Same thing for Hirschsprung. So you're going to get an abdominal film. That's the first test you're going to do. Later on, you may get barium enemas. You may get endoscopies and biopsies, depending on what the disease is. So meconium ileus is a very thick piece of meconium sitting there. And typically what you see with meconium ileus on the barium enema, this may be important on the test, is that the entire area of the colon distal of the bowel, distal to that meconium ileus, is underdeveloped, what they call a micro colon, as opposed to a Hirschsprung's, which we'll show you slides later, where you see a megacolon proximal to the obstruction. Right? So that's one way of telling them apart. You have to get an abdominal film, you're going to get a barium enema. A TE fistula. There's various kinds of TE fistulas, and what you're going to look for when you're reading the test question is a baby that has choking, coughing, gagging, spitting with the first feeds, because many times they're aspirating into their lungs. They usually have a proximal esophageal atresia, and that means that the food bolus can't go through, and then they'll have a distal fistula, and so you will see air distally in the belly because it goes in from through the fistula. But look for a baby that has coughing, gagging, choking, even with its first feeds. Necrotizing enterocolitis, we're going to discuss this and show you some pictures. Look for a preterm baby. Look for low APGARs. So these are babies that have had some kind of stress. They will, when feeds are instituted, you may notice some bloody stools and some abdominal distension. They can actually perforate. And the test of choice in this case is going to be, first of all, an abdominal film. Hirschsprung's disease, remember aganglionosis of a segment. Usually it's distal and it's in the rectum, and so you'll have a baby that doesn't stool. But in this case, when you do the barium enema, you'll see this huge megacolon. I'll show you x-rays in a second. Duodenal atresia, look for a baby that has bilious vomiting. That's the key when you're reading the test question. Bilious vomiting. It is a little more common in babies with Down syndrome. They'd be too nice on the exam to mention the baby has Down syndrome. Look for a baby that has bilious vomiting from the first feeds. Age is very important again. And we'll talk about jaundice in a minute. So here's a baby with meconium ileus, and the x-ray shows these dilated loops of bowel, and actually it looks like there might even be a perforation from it. You can see some free air over here. And so actually then this baby will then have, this baby has cystic fibrosis till proven otherwise. We'll talk about the diagnostic tests later. These are the different types of tracheoesophageal fistula. You don't have to know all the different types. You do have to know the basic pathophysiology. There's an obstruction in the esophagus, and there's usually a distal fistula, like you see on this very first one over here, where you have the esophageal atresia right there, and then there's the distal connection between the trachea and the esophagus, and that's how air gets into the distal. You will see air in the stomach. Otherwise, if it was just esophageal atresia, you wouldn't see air in the stomach. Another thing to remember with TE fistula, look for other abnormalities, particularly cardiac abnormalities. So once you diagnose these patients with TE fistulas, they all need an echocardiogram. They may need CT of the chest. Look for other abnormalities. This is duodenal atresia, the classic abdominal film, what we describe as the double bubble. So you're going to see the first bubble is the stomach, the other bubble is going to be the duodenum, and then there's nothing. That's because the duodenal atresia, there's no distal air after that. As opposed to, for example, a patient that might have a malrotation, in which case, depending on when it happened, you may have some distal air. That's something completely different. We'll talk about that in the GI section. So this is duodenal atresia, double bubble, bilious vomiting from birth. Can't give you any better clues than that. Call the surgeons. This is Hirschsprung's. What I'm trying to show you here is the barium enema, which shows that area where the arrow is, that's the stricture, that's where there's aganglionosis. If you notice, up above that, so if we go up here, this is all proximal to the obstruction. Look how big that is. That's why they call it congenital megacolon. Okay, so this is aganglionosis causes the obstruction. The normal bowel is all that other stuff, which is distended and dilated and trying to get through, trying to push the stool through. So a barium enema is very important for the diagnosis of Hirschsprung's. However, the definitive test, they like to ask, which is the best test to diagnose Hirschsprung's is going to be a biopsy, and it shows an area with no ganglion cells. Okay, so this is a picture of necrotizing enterocolitis. Remember, any of these abdominal diseases, the first thing you're going to get is an abdominal film, a plain abdominal film. I already said necrotizing enterocolitis is going to be look for a preterm baby, look for a baby with low APGAR scores. That's how they can ask you the APGAR score. Then when they introduce the feeds, the baby may develop bloody stools and possibly even abdominal distension. They can even get shocky. The first test you're going to do as far as abdominal films is going to be a plain abdominal film. You're going to look for the words pneumatosis intestinale. And on film, that's these areas right here that you see. This is air inside the bowel wall. And it goes in a lot of places. It comes down this way and down that way. Here's another round area with pneumatosis intestinale. In this particular case, you can see it going up the hepatobiliary tree. That is called pneumobilia. But the one you really want to look for, the words you're looking for, are pneumatosis intestinale. That is almost pathognomonic for necrotizing enterocolitis. Now, let's spend a little bit of time talking about jaundice in the newborn. You absolutely, positively have to know the definition of physiologic jaundice. You'll be reading the test question, and they'll be clicking off things, and you'll have to decide, first of all, if is this physiologic or is this pathologic. Okay? So physiologic jaundice usually occurs not in the first 24 hours of life. So there you go again. Look at the age of the patient. Not going to be present in the first 24 hours of life. If they're describing a baby that's 8, 10, 12, 14 years old, that's 14 hours old, who is getting jaundiced, it's not physiologic. So the first thing you need to remember, not present in the first 24 hours of life. Usually does not go above 12.9, 13. Okay? Usually peaks by the 3rd to 5th day, usually gone by 7 to 10 days, maybe a little bit later. 2 weeks will give you that much. Indirect hyperbilirubinemia. Okay? You have to know the definition of that. If it falls outside of that definition, then you need to start thinking of causes. Now, on the exam, they might give you a baby that is jaundiced and not in the first day of life, but a second or third day, it could still be pathologic. So just because it doesn't fit in, they might give you something to confuse you a little bit more. Physiologic jaundice occurs because babies are born with high circulating red blood cell counts and hemoglobin because they're a little hypoxic in utero. Erythropoietin is stimulated and you make red blood cells, you carry the hemoglobin around. When they're born, you have these high red blood cell counts. The red blood cells don't live as long in the newborn as they do in adults. Usually the life span of a red blood cell is 60 to 90 days in the newborn as opposed to 90 to 120 days in us. And so you have an increased turnover. The most common source of bilirubin is the hemoglobin molecule that's in the red blood cells. So you have this increased turnover of red blood cells, and you add on top of that a liver that's not fully mature yet, and that's how you can get physiologic jaundice. The liver can't metabolize that hemoglobin to bilirubin, or metabolize it and get it out, and so it kind of starts storing it in the tissue, and you get jaundiced. That's what happens with physiologic jaundice. Everything else is pathologic jaundice, and you have a nice diagram there, and we're going to divide it into direct and indirect. So again, when you're reading the test question, you're going to have some labs given to you. They're going to give you times, they're going to tell you how high it is, they're going to tell you if it's indirect or direct, and that leads you along your differential diagnosis. For the indirect hyperbilirubinemias, look for Coombs positive versus Coombs negative. Again, that is probably information they will give you in the stem of the question. Otherwise, they'll ask you what test do you want to do, and you'll want to order a Coombs test in addition to all these other tests that you might want to order. Coombs positive hemolytic anemias, think right away of Rh, ABO, and the minor blood group incompatibilities. Rh incompatibility is not as common as ABO. But it is treatable and certainly preventable by giving the baby or the mom Rh immune globulin after any miscarriage or after the birth of any Rh of the baby. The mom would be Rh negative, the baby's Rh positive, the mom would need immune globulin. The ABO is not as common, is much more common, but not as severe as the Rh. The ABO is not really preventable, but it's much more common, and usually you treat these, if necessary, with phototherapy. If the baby is Coombs negative, so that's another test you're going to need is Coombs, and you're going to need the mom and the baby's blood group and type. If the baby, you'll need a CBC, because the CBC will give you what the hemoglobin is. If the hemoglobin is high or the hemoglobin is low, that directs you along your diagnostic path also. So a high hemoglobin, think of, for example, polycythemia. Was this baby hypoxic in utero and now really hypoxic in utero and now has high hemoglobins? Was this an infant of a diabetic mother? We said they were polycythemic. Okay? Is there a twin-to-twin transfusion? So again, that's information you should be getting in the stem of the question. If the mom is born with twins, if there's a twin-to-twin transfusion, it means that one of the babies basically stole part of the blood supply from the other baby. That baby tends to be bigger. That baby tends to be ruddy and plethoric, and that baby tends to have the problems much more so than the tinier baby who's anemic. That one tends to do better, so it all evens out. Worry about maternal fetal transfusions. Sometimes there's extra blood going from the mom to the baby. The baby is born with higher hemoglobins. Obviously, intrauterine growth retardation, anything that causes chronic hypoxia to the baby will have higher hemoglobins. And infants of diabetic mothers that we've discussed as being ruddy and plethoric because of higher hemoglobin. If the baby has normal or low hemoglobins, think of hemolytic disease caused by enzyme problems or cell wall problems. These are usually not seen at birth. So remember these for later in life. Okay? For example, G6PD, glucose 6-phosphate dehydrogenase, that one is going to be something that you have an inciting, something that triggers it. And we'll talk about that later in the hematology chapter. So these are more membrane problems. They don't necessarily present right away. Direct hyperbilirubinemia, okay, you have a whole list there. Sepsis in the newborn. Sepsis can cause a lot of different things, so remember that one as a cause. The torch infections we're going to discuss shortly, and that stands for those congenital toxoplasmosis, rubella, cytomegalovirus, herpes, and syphilis. Babies can be on TPN, total parenteral nutrition. That can cause hyperbilirubinemia. And you have a whole list there. The big one is the one at the bottom, biliary atresia. Okay, that's a very common one to be asked on the exam. Look for a baby that is jaundiced at birth or shortly thereafter, that's jaundiced, and has direct hyperbilirubinemia, and they will describe what is known as acholic, clay-colored, or chalky stools. That means that the bilirubin is being conjugated, it just can't get out into the circulation. Bilirubin contributes to the stool color by forming coprobilinogen. If it's not getting out, you're going to get these descriptive stools. They call them clay-colored, chalky, or acholic stools. Okay? Those are the things you need to remember about jaundice. A couple other topics about jaundice is breastfeeding versus breast milk jaundice. Breastfeeding jaundice is usually earlier onset, less than 1 week of age. How important is it to look at the age of the patient when you're reading the question? Okay? Usually this results from dehydration. The baby may not be getting enough breast milk. It takes a couple of days for the breast milk to come in. There's a lot of things that influence the production of breast milk, including stress on the mom and all, so that if the baby's not getting enough breast milk, he gets a little bit dehydrated and he'll get jaundice. That's what's called breastfeeding jaundice as opposed to breast milk jaundice. This will be treated by giving the baby more frequent feeds and not necessarily supplementing, but just giving more frequent feeds. Breast milk jaundice usually occurs a little bit later. Look for a baby that's over a week of age. Breast milk, basically what it does, the non-esterified fatty acids in the breast milk may compete with bilirubin for the albumin molecule and kick the bilirubin out of the albumin molecule. The albumin molecule basically transports it around and the baby gets jaundiced. So again, look for the age of the baby. It peaks around the second to third week. Sometimes you may supplement these babies with some formula or whatever, and it gets them over it, and then that's the end of it and it goes away. These two really don't cause problems for the most part.